Welcome to Chapter 9, Speech Sound Disorders in Children. The focus questions for today's lecture include: what is a speech sound disorder? How are speech sound disorders classified? How are speech sound disorders identified and described? And how are speech sound disorders treated in evidence-based practice? Speech sound disorders become evident during the developmental period for speech sound acquisition from birth through age 9, when speech sounds are developing. One of the most prevalent types of communication impairments among children are speech sound disorders. 4 to 13% of children are affected overall, 4.5% of boys, and 3% of girls. Speech sound disorders can be defined as an impairment of an individual's sound system, resulting in a significant problem with speech sound production that differs from age and culturally based expectations. They can arise from an articulation impairment or a phonological impairment. And we'll look at the difference between those in just a little bit. Actually, now, an articulation impairment is an inability to articulate certain speech sounds correctly. It's known as a phonetic impairment. Phonological impairment involves the rules that govern sound patterns in a given language, and it's referred to as a phonemic impairment. Look at the differences between those two types of impairments. An articulation impairment is an inability to articulate certain speech sounds correctly, referred to as a phonetic impairment. Let's go back. An articulation impairment might be saying a T sound for a K sound. Phonological impairment involves the rules that govern sound patterns in a given language. It's known as a phonemic impairment. A phonological impairment involves different phonological processes. One of those is final consonant deletion, for example. A child might say ca for cat. They're leaving the final consonant off the end of the word. So it's not that they have an issue with necessarily producing the sound t, but it's more of a process of leaving off word endings or final consonants in words. The etiology or cause, 60% of these causes are unknown, which, as you can imagine, is unsettling to parents, because parents coming to see a clinician for a child's impairment, speech impairment, they're going to want to know what caused this, what could we have done differently. 40% can be attributed to recurrent middle ear infections, developmental motor speech disorders, and other developmental disorders. So recurrent ear infections are a pretty big percentage of the cause for delays in children's speech. Multicultural issues, dialectal and linguistic diversity. Speech variation. There are differences in speech arising from a dialect or a foreign accent. They're not considered a speech disorder. A variation in dialect is where speech and language variation is characteristic of a group of speakers from a particular region within a country. And foreign accent or language influenced speech in which characteristics are carried over from one language into another. And I will share with you that, contrary to what this is saying about it's not a speech disorder, sometimes it is a concern enough with people who want to enroll in accent reduction therapy. And actually, when I was in graduate school many moons ago, I actually had a client who was from somewhere in Asia, don't remember where, and he was a professor at ASU, and he wanted to reduce his accent because his students were having difficulty understanding him. And so I worked under the supervision of a clinical educator to help this man reduce his foreign accent. Key concepts that we'll look at. We'll look at each of these more in depth. Phonemes, International Phonetic Alphabet, pronunciation of English consonants, and pronunciation of American English vowels, and normal acquisition and development of speech sounds. So when we're looking at phonemes, to be considered a phoneme, a speech sound must be able to signal a contrast in meaning between two words of a language. The smallest unit of sound that can affect meaning, p and b, in the words pat versus bat. Obviously, those two words have very different meanings. And all we did was change one sound in the initial position of those words. The P being a bilabial sound that is considered voiceless, and B being a bilabial sound that is voiced. Standard American English uses about 40 sounds to create hundreds of thousands of words. An allophone is a variation of one phoneme. An example, pin versus spin. Co-articulation is the way sounds overlap during articulation, causing articulatory characteristics of phonemes to vary according to the context. Assimilation is the way the features of one sound take on the features of neighboring sounds. So a child might say goggy for doggy or lello for yellow. The International Phonetic Alphabet. It describes and clarifies each speech sound on the basis of how and where it is produced in the speech mechanism. The IPA represents each phoneme used in the world's languages, both vowels and consonants, as specific symbols. Pronunciation of English consonants. The classification of these consonants are place of production, manner of production, and voicing, and we'll look at each one of those a little bit closer. In reference to place of production, where in the vocal tract a sound is produced. Bilabial, both of the lips are involved, as in p, b, and labiodental, upper teeth and lower lip are involved, as in f and v. Linguadental, between the teeth, where v and th are produced. Alveolar, tongue and alveolar ridge. T is an example of this. D, s, z, n, and l are also examples of that. Palatal, tongue and hard palate. Is an example of this. Sh, j are also examples of this. Velar, the sounds are produced in the region of the soft palate. K, g, ng. And glottal, The sounds are produced at the level of the glottis, and is an example of that. Manner of production describes how a sound is produced. Stops are sounds that are produced with a complete obstruction of the vocal tract. And t and k, p, b, d, g are all examples of those. Fricatives are sounds that are produced with constriction or partial obstruction of the vocal tract. F, v, v, s, z, sh, j are examples of those. Affricates, partial obstruction followed by a release, as in ch. Nasals, velopharyngeal port is open, which allows for nasal resonance. Mm, are examples of those. Liquids are sounds that are produced with a relatively open vocal tract that is only somewhat more restricted than for vowel production. And the sound is an example of that. And glides are sounds that are produced with the gliding movement of the tongue, either toward a vowel or away from a vowel. Yeah, are examples of those. Voicing describes whether or not a sound is produced with a vocal fold vibration. Voiceless sounds are examples are p and t. And voiced, if you take your open hand and put your fingers over your throat and you say b and d, you can feel a vibration, and those are referred to as voiced. Pronunciation of American English vowels. Their vowels are characterized by 4 articulatory features, and those are tongue height, where the vertical dimension, the tongue movement, how high is the tongue when a vowel is produced. And vowels are classified as high vowels, mid vowels, or low vowels. High vowels obviously are vowels produced with the tongue in the highest position, mid vowels in the middle position with the mouth opening slightly larger, and low vowels are vowels produced with the tongue in the lowest position and the mouth opening is wide. Oh, let me go back just a second. And the tongue advancement refers to the horizontal dimension of tongue movement. How far forward is the tongue when a vowel is produced? And vowels are classified as front, central, or back. And then the roundness, are your lips rounded when a vowel is produced? There are rounded vowels and vowels that are neutral on lip rounding and unrounded vowels. And then tension, are the articulators tense or lax when the vowel is produced? Now we'll look at normal acquisition and development of speech sounds. There's a pre-linguistic period from birth to 12 months. These are all listed on table 9.3 on page 281 of the book in chapter 9. The pre-linguistic period of birth to 12 months can be described with early vocalizations that are reflexive and then become more purposeful. And the size and shape of the infant's vocal tract, as well as the child's neurological, respiratory, and laryngeal systems, determine the sounds that can be produced. First words from 12 to 18 months. Within the first 50 word stage of language development, lexical and phonological acquisition are closely intertwined as the child selects new words that include sounds that are in his or her phonetic repertoire. A whole word strategy is used to acquire vocabulary, and early development cannot be described in terms of individual phonemes because there's not a stable correspondence within and across lexical items. There's a phonemic period of 18 months to 4 years. During this time, there's a rapid increase in vocabulary that occurs after the first 50 word stage results in shifting from a whole word strategy to a rule-based strategy. And the relationship between sounds of the adult model and the child's pronunciation becomes more systematic or rule governed. And then the stabilization period, which is from 4 to 8 years, where the last phonemes needed for completion of the phonetic inventory are acquired, as well as more complex syllable structures such as consonant clusters. That's where your ST, ST sounds, stop, step will come in. How are speech sound disorders classified? Some are of unknown origin, and they're termed functional disorders. These include articulatory and phonological difficulties. And then others are known organic origin. These include structural deficits, sensory impairment, or a neurological impairment that results in a motor speech disorder. SLPs use a systematic and comprehensive process of assessment to identify phonological disorders in children. Speech assessment involves careful, informed observations and hypothesis testing. This is by Carolyn Bowen, who is a known specialist in the speech sound disorders area. Like other disorders that we've looked at in previous chapters, speech sound disorders will start out by having somebody make a referral. So the most common of these will be made by parents, pediatricians, or possibly an early childhood educator. Also, I'd like to throw in that sometimes friends of families might make suggestions to parents that the child is not being understood by them, and sometimes parents will then call a professional and ask about a referral being made. For children under 2, signs of a possible speech delay might include a suspected hearing loss or chronic ear infection, a known physical impairment, particularly of the oral facial structures, or a known mental or cognitive impairment. Some warning signs of a speech delay include delay in vocal play, babbling, appearance of first word, and use of two-word combinations, a limited phonetic inventory, where a child can only say certain sounds or certain vowels, intelligibility of early words to familiar caregivers of less than 50%, and reliance on gestures to communicate needs and wants. Then after the referral is made, a screening might take place as an informal observation. It's a relatively short assessment of the child's speech. The purpose is to identify whether a child may have a speech delay that requires assessment. This could be a clinician talking to a child for maybe 5 to 10 minutes. Informal tasks might include asking the child to answer simple questions, such as what is your favorite toy or game or movie, or to repeat a short list of words that sample early, mid, and later developing phonemes, possibly reciting the alphabet or counting if appropriate. And then, if deemed necessary, a diagnostic speech assessment might be warranted. In this case, a case history interview and or questionnaire will be obtained. An oral mechanism screening will take place, and a hearing screening, along with the language screening and evaluation, and a speech assessment. And we'll look at each of these a little bit more closely. along with an analysis of speech performance. Um, in looking at a diagnostic speech assessment, this is designed to achieve 6 goals: characterize child's general developmental background, including family characteristics; characterize the status of auditory and oral structures and functions. Like we said previously, hearing can impact speech development. Characterize current phonological and language performance. Characterize the nature and severity of the speech sound disorder. Determine the prognosis for phonological outcomes, and determine the course of intervention. So looking at the case history, interview, and/or questionnaire. The case history enables the clinician to recognize cultural factors that might influence the assessment, to develop familiarity with the family that can facilitate the assessment process, and to understand family variables that may complicate or complement the child's speech development. Then looking at an oral mechanism screening. This is a careful examination of the structures and functioning of the speech mechanism. It includes looking at the lips, teeth, tongue, hard palate, and soft palate, and how those deviations in any of those might hinder speech production. If you look at the table 9.6 on page 288 in the book, it's going to give you specific structures and functions to be looking for in each of those areas of lips, teeth, tongue, hard palate, and soft palate. Then next, looking at a hearing screening. This is completed to rule out the possibility that a hearing impairment is the cause of speech difficulties. The SLP should speak with parents about any hearing difficulties that are present. And then from there, you would move to a language screening or evaluation. The SLP should assess expressive and receptive language skills as well as phonological awareness skills. And this could be done as part of a screening. If the parent is not concerned at all about the child's language development, and in the first few minutes of talking with the child seems like his language is intact, a screening might be all that is necessary. If there are questions about a child's language development, then a full evaluation might be warranted. Children who exhibit a speech sound disorder can also have problems with language development, including grammar and vocabulary. So it is important to assess the language, whether through a screening or further evaluation. Then looking at the speech assessment, you're going to look at production of sounds in single words and connected speech. You're going to look at stimulability, which is the ability to correctly imitate an incorrect sound with cues. So if a child incorrectly produces k, you're going to use a cue telling the child that that sound is made towards the back of their mouth or in their throat. And you're going to try to get them to correctly imitate a production of the k sound to see if they're stimulable for that sound. Then you're going to look at consistency, which refers to the extent to which a child's pronunciation of a word or sound stays the same over different productions. And different methods are used to evaluate consistency. You can look at standardized tests, and you can do word probes with the child, in which the child repeats several words that he or she produced incorrectly on a single word test to see if that child produces it consistently or inconsistently. And then looking at severity, the test scores or percent of the consonants correct will be looked at to see if you can, that you will be calculating the consonant production accuracy on a sample of connected speech that includes at least 200 intelligible words. Sometimes this can be done in smaller samples of single word productions. You're going to look at sound inventory tests to assess articulatory skills. The Goldman-Fristow test of articulation, second edition, is one of those sound inventory tests that is widely used. There are others that are on the market, but the Goldman-Fristow is kind of the gold standard. Looking at phonological pattern tests, they're going to assess phonological error patterns, and two of the main assessments used for this are Hodson assessment of phonological patterns and the Kahn-Lewis phonological analysis. So in looking at the analysis of the speech performance, you're going to look at key outcomes of the assessment, analysis of data and speech and language samples to identify predominant error patterns. And you're going to look at making a differential diagnosis. You're going to determine appropriate treatment targets and design an effective intervention plan based on the diagnosis and looking at the targets that are determined for treatment. A relational analysis is going to provide a description of the child's sound errors in relation to adult standard in a one-to-one comparison of child-adult production. And an error analysis is going to be helpful because only error sounds are analyzed. Generally, relational analyses are completed on whole word transcriptions from shorter single word samples, and relational analyses are typically best suited for children who have mild to moderate speech disorders because their sound systems are more intact. Then looking at an independent analysis, this is going to examine a child's sound system independent of adult sound system and includes a description of child's phonetic inventory and phonotactic patterns. A phonotactic pattern is referring to the syllable structure and distribution of sounds in the child's language. Looking at evidence-based practice, which is what you're going to base your treatment on. There are some fads and fallacies to consider. One of these being oral motor exercises. There has been much research done on the effectiveness of non-speech oral motor exercises, as they're called, to develop that these are developed to exercise speech musculature in order to improve speech sound production. And it is found that these on their own, the oral motor exercises on their own, is not necessarily an evidence-based practice for making somebody have more effective speech. The oral motor exercises are sometimes used in conjunction with weakening muscles if caused by something like dysarthria or a stroke, something like that. But in and of themselves, oral motor exercises, even though they are used by approximately 85% of clinicians on their own, are not reported to be best practice. The intent of evidence-based practice with regard to intervention is to promote the adoption of effective protocols that are research-based, and to delay the adoption of unproven protocols and to prevent the adoption of ineffective interventions. ASHA, the American Speech Hearing Language Association, is our governing body nationally for speech language pathologists and audiologists who ASHA is kind of the umbrella under which practices are accepted or not accepted. and to drive home the point through evidence-based practice that speech therapy does work. An overview of effective approaches. Homonymy and unintelligible speech, contrastive approaches. We'll look at that first. And then limited phonetic inventory and poor stability is under the stimulability approach. And then inconsistent speech errors or under the core vocabulary approach. And speech sound disorders and phonological awareness deficits under the metaphonological approach. We'll look at each of those individually, along with childhood apraxia of speech, using a dynamic temporal and tactile cueing approach. First, homonymy and unintelligible speech, contrastive approaches. Looking at minimal pairs and multiple opposites and complexity approaches. The minimal pairs approach contrasts the target sound with its one-to-one error substitute, whereas the multiple oppositions approach contrasts multiple target sounds, up to 4, from across a rule set of a phoneme collapse with an errored sound. And the complexity approach looks at maximal oppositions and empty set, and looks at how homonymy indirectly, by contrasting a target sound with a known independent and maximally different comparison sound, or by contrasting two target sounds that are unknown, independent, and maximally different in an empty set. This is further explained on table 9 or in table 9.9 on page 296 in the book, where it looks at each of these approaches and the nature of the contrast. The site of the contrast, it gives examples of each of these and looks at the homonymity. And looking at the parameters of each of these, like I said, in the table 9.9 looks at nature of contrast, the size of the contrast, and how the homonymity is addressed. Then looking at the stimulability approach, it involves turn-taking activities. It's intended to be short-term. The goal for this is stimulability and not acquisition. So you're just looking at if the child can make a specific sound. Inconsistent speech errors are the core vocabulary approach. This was developed to establish consistent word productions for the 10% or so of children with speech sound disorders who make inconsistent errors. The goal is to teach how to plan the sequence of phonemes for a specific vocabulary word so the word can be produced consistently. Each week, the child is going to learn to consistently produce his or her best production of up to 10 vocabulary words, building in complexity from isolation to connected speech. The sessions are going to consist of dense practice drills in this approach. Then looking at speech sound disorders and phonological awareness deficits, a meta-phonological approach. This approach encourages a conscious awareness of the structure of words and the sounds that make up the words. The goal of this intervention is to increase awareness of words formed, and how child speech differs from the adult target. So in order to facilitate speech and language and literacy acquisition, it's going to look at how their own speech differs from adult targets. Then looking at childhood apraxia of speech, or CAS, I'm looking at the dynamic temporal and tactile cueing approach. In this approach, a use of hierarchy of temporal delay is used. An emphasis is on tactile and visual cueing. And there's an incorporation of motor learning principles. Let me go back to that for just a minute. I'm going to touch on that a little bit more. So the use of hierarchy of temporal delay is simultaneous production, immediate repetition, repetition after the delay, and spontaneous production to allow the child to take increasing responsibility for building and retrieving motor plans with progressively less cueing. And then the emphasis on tactile and visual cueing is looking at phonetic placement, tactile cueing, and prosodic cueing, which is gradually faded with repeated practice. And then thirdly, the incorporation of the motor learning principles is going to look at mass versus distributed practice, the amount of practice, how practice is organized within a session, and type and frequency of feedback, with a high number of practice trials completed in short, frequent sessions. For example, twice daily sessions 5 times per week, which is optimal for children with childhood apraxia of speech. Best practice for childhood apraxia of speech is more frequent, shorter sessions during the week. Then looking at client and caregiver perspectives related to treatment. Speech sound disorders are the most common communication concern among parents and teachers of preschool children. And working mainly with preschool children, I definitely agree that these are the most common communication concerns among parents and teachers. They, want their children to be understood by the average listener, and so parents are going to seek treatment for their children if they are unintelligible to the average listener. So children with the speech sound disorders focus on problems of the listeners rather than on their own speech difficulties. And goals and targets and interventions for speech sound disorders. What is targeted in intervention may be as important as how it is targeted. So when you're looking at what to target, know that that's going to be very important. In the hierarchy of speech sound development, you don't want to be working on an R sound with a 2 or 3-year-old when it's not developmentally appropriate. We're going to look at some of the approaches to target selection, the developmental approach, the complexity approach, and the systemic approach. Let me go back to that. In the developmental approach, this is based on selection of targets that develop early and follow a certain developmental sequence and are assumed to be easier to produce by the child. This perspective is based on phonetic factors, including developmental norms, stimulability, and consistency of error. Targets will be selected that are early to develop, stimulable, and produce correctly in some contexts. The assumption is that sound learning has a motoric basis and should follow a sequential order based on ease of acquisition. Then looking at the complexity approach, this recommends targeting sounds that are late in developing, non-stimulable, and always incorrect. The approach reflects a shift from the traditional developmental approach of phonetic sound learning to one based on a phonemic system shifting. The assumption is that presenting more complex linguistic input to the child will not only force the child to learn the complex target, but also lead to the child's learning simpler, untrained sounds. And then looking at the systemic approach, this is described in which the selection of treatment targets is based on the unique organization and characteristics of each child's own language rather than on the characteristics of the target sound itself. And then looking at discharge of a client. This refers to the length of time in intervention. It's typically dependent upon age, severity of the disorder, and the type of the intervention adopted. So The intervention intensity refers to the amount of practice required within a set intervention period to achieve a desired outcome, and includes the number of responses, the frequency, and total intervention duration, such as 100 responses per session at 1 session per week for 10 weeks. It is suggested that a minimum of 50 practice trials per 30-minute session for 30 sessions is needed for an intervention to be effective, with 70 trials per session for 40 sessions needed for children who have more severe speech sound disorders. The length of time required in intervention to normalize children's speech can range anywhere from 3 to 19 months. And this is a range, obviously, probably not less than 3 months, but sometimes it does take more than 19 months, depending on if there are other variables involving, say, intellectual ability for the child. That's the end of the lecture for Chapter 9, and thanks for listening.